do you actually want to do it? Yeah. So now it's actually going. And 0.73 mils is not much. It's not even a mil, so it's very difficult to see. Another thing to point out is we have the brown sticker on there that says it's a subcutaneous route, and they'll often have a subcut butterfly in their abdomen for long-term use. They can stay in for up to a week before they have to be changed. So I will pass this around. Just have a play. You don't need to, you can take it in, take it out, restart, turn it off, whatever you want to do. Just have a look. They are locked as well. So when we've set them up and they're all ready to go, that's the instructions. I'll give out some instructions. We lock them up because it is an S8 medication. We want them to be safe. We don't want anyone to play with it. And we also can't change the rate. So it's not an adjustable medication. Once you've drawn it up, that's it for the 24-hour period. If you need to change it, you need to discard appropriately and redo the whole thing. So that's why double checking is very important as well. We still use the checklist on the wards, even though we do them quite frequently, just to make sure that we're completing the correct steps. So it's not to say that we don't know what we're doing, but it's just to make sure that we are doing the right thing each and every time by our patients. Just have a look at it, have a play. If you want to sit in groups, you can do that as well. So this is what a syringe driver looks like if you're not looking at that one right now. So you can see here while it's actually running. So this is what it looks like when it's actually running away. It tells you how much time is left, the rate that it's running at, and that it's saying that it's delivering. So it has all the buttons on there that are needed. So just have a look at that and keep going. So who's had or who's watched someone or who's played with one, sometimes in the community? You've seen one or played with one?
Driver.
Yeah?
Yeah.
Yeah? How did you go with it? Like, how did you find them?
It's just like you've got to do all your checks and check the battery and check your rights of medication and thing. And usually, like, they're like palliative, war, pain exacerbation are coming from home, like cancer patients and that butterfly lip and stuff. And they just sit in a little bag and under their bed, and then as you said, like once it's set, it's set. Yeah. So did you have to do any checks after you'd started it? Like with the other nurses, you have like two of the RNs in the room while they're doing all that. But we don't take a paper form check to the outside.
That's fine. That's just what we do. Just to make sure we're doing the right thing. So what about the infusions running? What checks do you think you need to do on your patient? Yeah. Where we actually connected it to. Make sure that's soft, not infected, not red, not hot or swollen. Make sure it's in date. Yeah, anyone else?
Check the battery.
Check the battery, yes. Very important. So, has anyone seen the checklist? There's actually like an observations chart for it. Yeah. So on that observation chart, we actually go through a lot of the information that's on the home screen of the syringe driver. So we check the battery life. So you can actually see it decreasing every 2 hours or however often the unit you're in has to check it. It says you double check the rate that it's running at and you see the volume, it will actually tell you the volume amount infused and the volume amount remaining so that you can have that information. We should be checking the site, making sure that's fine, and also the connection to make sure it's not kinked. Because that does happen sometimes. The patient might roll, might become kinked, and then they're not actually getting the medication that we want them to be given. Yeah, cool. So while we're looking at the syringe driver, we sometimes use PCAs. That's more in an acute phase because the patient can deliver themselves the medication. There is a continuous section on there as well, but this allows multiple medications to be used at one time, which is the benefit of using that over a patient-controlled analgesic pump. So, like I said, we usually use an opiate, whether it's hydromorphone or morphine, and we use midazolam. Has anyone seen a patient being agitated at the end of life? Yeah. So it's not so bad for the patient, but who sits with that patient?
The
The family. So the main reason why I wanted to go over this topic was for my staff, because I'm going to deliver it to them as well, is because we need to make sure that not only the patient is comfortable, but that those family members are having the best experience. It's not a great experience, but we want to make it the best kind of end-of-life experience that that they can have. Their family member or a friend is dying, and we want to show them that their family member is looked after, is comfortable, is not in pain, is being as best cared for as possible and having a good end-of-life experience. And pain relief is a major, major part of that, which is why this is so important. And it doesn't matter what unit you're in, if you're in the community, if you're in an acute hospital, if you're in coronary care, ICU, medical, whatever it might be, there are always going to be people that die. And we, as nurses, really need to be their advocate. That's one of our main roles, is to advocate for our patient. So if we are delivering pain relief and we feel it's not enough, not adequate, they still might have syringe driver, they still might be getting regular pain relief. If we feel it's not enough, we really need to escalate that and ask for something more, ask them to be reviewed, because that's our job to look after them. Okay, so talking about pain management, other than medications, say you're at home, got some pain, other than taking meds, what do? What have some of you guys done?
Heat or
Heat pass? Yeah.
Yeah.
Ice?
Mobility.
Yeah, moving around. Yeah.
Position.
Have you heard the doctors tell patients, oh, just go for a walk.
Go for a
You're,
walk.
you're probably just a bit stiff. Somebody else said something? Repositioning, yeah. Music, yeah. So distraction techniques are actually really good. Sometimes if I'm at home, I have a hot shower and just have it running on my back if I need to. Hannah, anything that you've done?
I think that covers it.
Yeah.
I think distraction is a big thing.
Yeah.
Very often, your patient will be pain-free when their family's there, and then as soon as they leave, they're in heaps of pain again.
Yeah.
Because it's all they can think about at the time.
Exactly. So thinking about other forms of pain relief is super important. I think some people get really hooked on, not themselves, but hooked on the idea of pain relief, that getting something, whether it's tablet or an injection, will fix their pain. But there are other ways to relieve, maybe not remove, but to relieve pain. So we've said a lot of these. So heat packs, a bath. In hospital you can't have a bath, but having a nice warm shower. Have you ever actually had a patient who's been in bed for 3 days and then they have a shower and then they're like, oh, I'm like a different person? That's so true. Repositioning, we said, so they might have been in bed all day long, and then we might just need to sit them in the chair because we've got pressure on a different part of their body, or get them an air mattress or whatever it may be. Massage, so there's pressure points. Some people really like being massaged. I'm not going to say touched, massaged. But family members can do that. You often see a family member sitting with them, holding their hand or massaging their hands. That's a really good thing that we can suggest. Mobilizing or exercise if tolerated, and deep breathing meditation. So things like music, radio, TV, if there's something that they really like, something to get their mind off it. So anything else? Any questions anyone has about pain management? Anything about the types of pain relief we use? Anyone's experiences with giving pain relief? Or using other methods, how they worked, how they didn't work?
Is it common in palliative to link with like a pain clinic? Do you not kind of liaise with them, or not really at that stage?
So there's, I guess, two different palliative care patients, right? So there's those that get involved with palliative care early because they know that their disease is going to progress and it's going to become, they're going to die from it. And palliative care is not about dying per se. Palliative care is about ensuring that the patient's progression through their disease to the end is as comfortable as possible. So that patient might not be dying for a year or two, but they know that they are and that they will. And getting them involved with palliative care early is super important so that they become comfortable with their provider and that they become comfortable with, what's going to happen with them. So they might start on medication, a small amount of medication, and then through their disease progression, they might up titrate. So they might start on a morphine tablet, then they might go to a patch, a fentanyl patch, then they might go to lozenges or in addition. So they build upon it. So the palliative care team are usually quite self-sufficient with providing their medication therapies, but they do liaise quite often with pain teams if needed. Yeah. Has anyone had a good experience with a palliative care patient or someone that knew that they were dying?
I had like a really she was end stage CA cancer, and she just the pain management wouldn't work for her, endone wouldn't work, and I remember over a period of my 5-week placement there, she had hydromorph, morph, fentanyl, all these different for 4 days at a time they would try different measurements and different opioids and stuff all at the same time, and it was interesting to see how they would each affect her just by the milligram of each drug to make her comfortable, and that was quite complex to find that balance for her.
Yeah, and a lot of it is that it's not just let's start morphine, they're going to get better or they're going to feel great.
Yeah.
A lot of it is starting at the bottom of the ladder, so with Panadol in the initial stages, and then adding to that. So they'll still have just because you're starting on morphine doesn't mean you get rid of the Panadol. They all have a different role to play, and they all, we talked about, all have different actions on pain. Even all the nociceptive pain act on different things. Ibuprofen and Panadol we use in regular patient populations for different reasons, right? Yeah, it's the same story. So we have to be really patient with these patients because they might come in with a pain crisis, and it is for them, it is a really important thing to be heard regarding their pain, and we can't just push it off and be they're always in pain, look at all these meds they're on, because we might look at their OBS chart or med chart and be they're on morphine, they're on endone, they've got PRN this, they've got whatever charted, and sometimes, not saying you'll do or anyone has, but there is the potential for people to be judged because of their pain meds. But pain is real and it's different for everybody. You might have 2 patients that are exactly the same disease progression who feel their pain differently, and we have to take their word for it because pain is the patient's experience of it. We do a pain chart, right? We do 1 to 10. We don't look at them and say, you're half smiley, I'll give you a 4. But, we ask them, and in conjunction with their response, we say, they're a 10, okay, well, they're a 10. I'll go get them some pain relief. Even if they look or don't look uncomfortable. So it's a very, pain is often not, and this is without palliative care, when we do our general observations, how often do we ask when we do their blood pressure, do you have any pain? Unless, there might be post-surgery, and then you're you're post-op, maybe I should ask them about their pain. Or you're in cardiology, do you have any chest pain? We don't ask them often enough, and it is part of our observation chart to do a pain score whenever our observations are due. Okay, any other questions? Have you had any experiences, Hannah?
One I can think of was working, I worked as an AIN in an aged care facility before I was an RN, and we had a lady who came just for end-of-life care, and she was quite independent, but she was dying, and she had a syringe driver, but it just had metoclopramide in it. She wasn't requiring, anything for her pain as such, but her nausea was her main source of discomfort. So she just had an antiemetic on board, and they would come in and fill it up every 24 hours. Yeah. So I found that interesting because and so that was a nice experience. Yeah.
And it is all subjective, and it's all really from the patient and the family's point of view. If a family member comes and says, oh, I think Dad needs some pain relief, that family member probably knows, because they've probably been with them through this whole experience of their journey with end-of-life care. And we as, I guess, nurses and as their advocate should be fighting for them to be as comfortable, as pain-free as possible, because, who needs pain at the end of their life when they want to lay there and talk to their family or enjoy the music that's playing without being distracted by the pain that they've got. So in summary, I just really want to hit home that no matter where you're working, that palliative care is super important. We don't have a specific palliative care ward here, so our palliative care patients end up everywhere, all throughout the hospital, from ICU to medical ward. We get them in the community and ED, and we can experience having a patient in the end of life no matter what unit we're working in. So it's really important that this is a skill that you learn as a basic, pretty much standard skill. So pain relief is multifactorial, so there is medications that we can give, and there's different types of pain medication. So we need to be aware of that as well. Understanding the different and various routes of administration. So we talked about them, our oral and IV and IM and subcut. They're multiple, and making sure that the route we're giving is the most satisfactory to the patient. Lastly, a syringe drive is a good way to administer ongoing analgesia, and like Hannah said, other medications like metoclopramide or haloperidol if they're super agitated, so that we're not constantly jabbing them and having to, be there. It also allows them to be in the community if needs be, and then a community nurse can just go change it every 24 hours so that that patient can be with their family. In addition to pain medications, there are other ways to assess pain and to help pain management in the palliative patient. And they're really good things to employ if you've tried a lot of pain meds and you feel like you're not getting anywhere. Maybe just try some different things like a heat back, which we do have on the wards, some ice, some music, etc. So if there's no other questions, everyone's happy? Yeah. So we'll just close up. I did give some people some evaluation forms to fill out. So just fill it out, be honest, share some comments, and then you can leave it on the table in the front there. Next week, for those who are here, we're going to continue our series on palliative care, but we're going to be talking about other palliative care interventions and how we can, implement care plans related to palliative care. All right. So thank you, everybody. Thank you. That's syringe drive.